Hello and welcome to Med One Pager. My name is Benjamin, and if you're interested in high yield clinical discussions about different topics, whether you're a medical student or you're a practicing doctor, this is a channel that you should be subscribed to. So don't forget to subscribe so that you don't miss out on the next video. And let's get started. So studies show that 80% of black women are going to be more likely to be diagnosed with fibroids by the time they're age 50, and about 2 to 3 out of 10 women you meet, one of them has fibroids. Why are they not in the hospital? Why are they not having all the different features we're going to look at? Is something that is actually interesting, because the most of these fibroids are going to be asymptomatic and are going to be found incidentally or diagnosed incidentally. But here's what you need to know. So fibroids, they're benign monoclonal smooth muscle tumors of the uterine myometrium, meaning they're coming from a single line of cells, and they are also sometimes called leiomyomas, or they are simply called myomas, which means leiomyoma means a smooth muscle tumor. So it is hormone sensitive, and that is why you're going to see that during the reproductive age, when we have the different plays of estrogen and progesterone, that is when we are going to have the most of the fibroids growing, and most of the time after menopause they go ahead and shrink, and rarely are people operated on after menopause for these specific tumors. So it is the commonest benign pelvic tumor, meaning it does not metastasize most of the time. That being said, sometimes about 1% of these tumors can undergo what we call a sarcomatous change, and they turn into a cancerous tumor. So the risk factors, being black, increases the rate. Ages between 30 and 50, a family history of obesity, hypertension, nulliparity, early menarche, and vitamin D deficiency. So when you look at nulliparity and early menarche, most of these conditions, these people who are being, it means they have been exposed to these cycles of estrogen and progesterone for a longer time, and therefore their chances of developing an estrogen or progesterone driven tumor tend to kind of increase. And you realize that most of these gyne cancers are going to be increased in people who have early menarche, as well as people who have nulliparity, who have not had children. So some of the the factors that may reduce the risk factors include pregnancy, because once you're pregnant, you get a break from these fluctuations in hormones for about 9 months, and this helps reduce the risk of developing the tumor. Menopause, obviously, then possibly hormonal contraception, because again, these combined oral contraceptive pills or the hormonal pills again go ahead and disrupt the normal cycles of this hormone, the cyclic changes, and this is going to be good. And then smoking. So when you look at the pathophysiology, we have myometrium mutation. A mutation occurs, and this is where most cancers are going to begin from. It's going to cause a monoclonal smooth muscle growth, and then extracellular matrix is going to be deposited, which is going to form this firm walled mass. And most of the times when you touch or feel a fibroid, it has the consistency of rubber. So as the reproductive cycle continues, estrogen and progesterone are going to be growing, and we know that these hormones have different effects on these different muscles that are growing. So they're going to cause growth in size, as well as vascular changes, where we're going to have angiogenesis, of development of new blood vessels and things like that. So what happens is that the cavity of the uterus is going to be distorted. There's going to be this bulging inwards, especially if you have a submucosal fibroid. It's going to cause this bulge, and this bulge is going to increase the endometrial surface area. And once you increase the endometrial surface area and estrogen comes in and progesterone, that endometrium is going to be bigger, and you're going to have things like increased bleeding. But when the woman is pregnant and they give birth, you find that this area that has a bulge in it cannot actually contract very well, and that is going to cause the bleeding, as well as that area that has the fibroid is going to have very poor vascularization or fragile blood vessels, and that will also contribute eventually to the bleeding. Then the pressure symptoms that are going to fulfill are going to be an enlarged uterus. Is going to, of course, increase in size because it's having a tumor, and when it's increasing in size, it's going to compress the neighboring things. It's going to compress the bladder, the rectum, the ureter, and the pelvic nerve, and these can cause different manifestations. Then infertility is going to occur because we have distortion of the cavity of the uterus, and most of the time if you find that the fibroid is not submucosal, or it's not distorting the cavity, and the woman is not giving birth, then most of the time it's not an infertility related to pregnancy. So you'll find we have things like subfertility and things like that, and early pregnancy losses, or around second trimester pregnancy losses, that are going to be heavily associated with fibroids. And then we have the altered contractions also, that are, and tubal osteoblockage. These are going to interfere with the sperm motility towards the eggs or the ovum. So when you look at the classification, we have the submucosal fibroids, and these ones are found that they are inside the uterine cavity. They are projecting towards the uterine cavity. Then we go ahead and have the intramural. These ones are going to be found within the muscle of the uterus, the intramural fibroids. Then we have the subserosal. We have the serosa around the one that is covering the uterus outside. There can be a fibroid there. Then we have the pedunculated type, which actually has a stalk, and this one has the highest risk of torsion, because as you can see, it can always twist around this and cause all kinds of pain. Sometimes they are pedunculated and they are coming from the uterus and going down into the vaginal canal through the cervix. Then we have the cervical or the broad ligament or the parasitic. Now these ones are the atypical sites, and these ones are going to basically just go maybe on the cervix. It's going to implant there and grow. It may go on the broad ligament and also grow around there. So when we look at the subtypes by the FIGO, that is the body that is seen to grade a lot of these cancers. They came up with the gradings from 0 to 8, and most of the books are going to stop at 4. So at 0 we have a pedunculated intracavitary. This is a type of fibroid that is pedunculated, but it's within the cavity of the uterus. We have the submucosal, and these ones are going to be grouped into two. We have one where 50%, where less than 50% is with the muscle. It is, yes, inside the cavity, but 50%, less than 50% is in the muscle. Then we have the submucosal, where more than 50% of it is in the muscle and only a bit is bulging into the cavity. Then we have the grade 3 or the type 3, the one that contacts the endometrium and it's intramural. Then we have the pure intramural, which is totally inside. You don't see it inside the cavity. We have the subserosal, which is more than 50% intramural, and the subserosal, which is less than 50% intramural. Then we have the pedunculated subserosal, and then the other types are in grade O type 8. And then we have the hybrid, where we have the one that contacts both the endometrium and the serosa. So when you look at the clinical features, the most common presentation is going to be asymptomatic. Most of the time this woman is going to have the fibroids, but they will not have any symptoms, they are not having any pain, and they may continue actually to go on with their lives like that. But then we have things like bleeding. This is heavy menstrual bleeding that is going to be very, very common, and that is going to be especially, and sometimes they have the prolonged menses, as well as clots and iron. They have anemia, iron deficiency anemia, and this is because they have prolonged bleeding a lot of the time. Then we have pain, that is dysmenorrhea. This is because of the distortion of the cavity or the muscle disruption. We have pelvic pain, we have degeneration pain, and we have torsion pain, and we shall look at what degeneration is in fibroids soon. When you look at the pressure, we have pelvic heaviness. Sometimes they feel like they really do have a mass within the pelvis. They have a firm abdominal mass when you try to palpate. They have frequency. This means they are urinating very many times because this is compressing the bladder. They have urgency where they feel they need to urinate. Even when they have just urinated, sometimes they get retention depending on where the fibroid is going ahead to press on the bladder. And then we have constipation, and that is due to compression of the rectum behind. It can cause backache. It can cause hygronephrosis, especially if the ureters are compressed and then the urine goes ahead and backs up towards the kidneys. So when you look at fertility, it's another common presentation that would come with fertility, implantation failure, and recurrent miscarriage, especially in the second trimester when the fetus is becoming bigger. It finds that the space within the uterus is no longer big enough, and then they go ahead and get a miscarriage. So pregnancy related, we have the rate degeneration, and this is a type of degeneration that commonly occurs within pregnancy, and degeneration occurs most of the time in fibroids because they are outgrowing their blood supply. So when we have rate degeneration, you may find that they develop a kind of fever and pain, and most of the time this is going to be managed conservatively. Remember, you never operate on a gravid uterus for fibroids because the risk of bleeding is too high. So we have miscarriage, preterm labor, malpresentation. Again, the fibroid may interfere with how the baby rotates to bring the head downwards. That could cause a malpresentation. It can cause abruption, it can cause obstructed labor, and it can lead to cesarean sections as well as postpartum hemorrhage. So when you do the general examination, you'll find that they have pallor, they have the pulse is raised, they have the BP that is going to vary, and then you want to take their BMI. Abdomen examination, you may find they have a mass, they have tenderness, and you also want to know the size of the uterus. They may have a uterus of the size of around 10 weeks or 15 weeks, something like that. When you do the speculum examination, you want to see the cervix, you want to see the source of the bleeding, you want to see perhaps fibroid. Sometimes that fibroid comes from the cavity and collapses downwards into the cervix. On binomial palpation, you want to see an enlarged regular mobile uterus and an adnexal mass. So most of the time when you do the bimanual, you're going to feel that the uterus is irregularly enlarged, and the classic finding is an enlarged irregular mobile uterus. And this is what is going to differentiate it from adenomyosis most of the times, because we saw in the video of adenomyosis, if you have not seen it, it's in the playlist, where we have endometrial tissue growing into the muscle and it causes that symmetric enlargement of the uterus. So when we have degeneration, it's because most of the time we are outgrowing the fibroid, and the most common, we have the hyaline degeneration, that is the most common type. We have the cystic degeneration, where the fibroid kind of develops a cyst inside. We have the calcific, where calcium is deposited into the fibroid, and we have issues like that. We have the rate degeneration, and this one is the one that classically occurs in pregnancy. So if you are being tested upon something of a sort that tries to bring about a fever in pregnancy, think about degeneration, and the management is purely supportive, and you should not interfere with the pregnancy or things like that. Then we have fatty degeneration, mixed with degeneration. We have like mucus-like substances being deposited there, and well as the creative degeneration of the fibroids. So when you look at the complication, we have the gyne complications, that is heavy menstrual bleeding, iron deficiency, anemia, pain, infertility, miscarriage, torsion. Again, these are things that we have already looked back. Think about them in terms of the gyne, the OBS, as well as the treatment complications. And some of the treatment complications include things like recurrences, especially you may operate on this person and then they go ahead again and have new fibroids form, sometimes even the drugs. And one thing that is important to know is that the definitive management of fibroids will eventually be surgery, but sometimes we use drugs to reduce the size of these fibroids, because we know that the fibroids are hormonally driven. So if you give hormonal blockers for the different hormones that actually cause the fibroids, then you may have them shrinking, and then you get to have an easier kind of surgery. Surgery may cause adhesions, bleeding. Sometimes if you are tampering with the ovaries, you may have a decrease in the ovarian reserve because you're reducing the number of ovaries, and this can cause issues with fertility. There's uterine artery embolization, especially that one. It's going to affect the uterine reserve. Then infertility after hysterectomy or ablation is also a serious complication to consider. So when you look at the differentials, if the person is bleeding, you think about pregnancy, adenomyosis. This is a very common differential. A polyp, endometrial hyperplasia, that is anyone who's above the age of 45 and they're having vaginal bleeding, the first thing you want to do is an endometrial biopsy and rule out endometrial cancer. You want to rule out cervical cancer, coagulopathy, ovulatory dysfunction, thyroid disease, and uterine devices or drugs, because we know some of these oral contraceptives can actually cause abnormal vaginal bleeding. So if it is a mass, you want to consider pregnancy, ovarian tumor or cyst. You want to consider adenomyosis, endometrioma, a PID, sarcoma, or a full bladder. Then pain can be ectopic, can be the PID, can be endometriosis, can be an ovarian torsion, can be appendicitis, can be a UTI, and it can also be a bowel disease. So when it comes to investigations, you want to do the basic investigations: a pregnancy test, a full blood count, ferritin, blood grouping, and cross matching, especially if there has been severe bleeding or they have features of anemia. Then you want to do the TSH for irregular bleeding, that is a thyroid stimulating hormone, because we know that in conditions like hyperthyroidism and hypothyroidism, we have changes in we have menstrual irregularities. You can have hypo or hypermenorrhea. You can have increased menses, or you can have things like missed menses or missed periods, especially when you have hypothyroidism. Then you want to do coagulation studies if there is a bleeding disorder. You want to do renal function tests, especially if there is a suspected obstruction, thinking of hydronephrosis, which could cause then the backflow that damages the kidneys. You want to do a pap smear for HIV, and then an STI test if you suspect that be having an infection that could eventually lead into pelvic inflammatory disease. And I did a video about pelvic inflammatory disease, which is one of the high risk causes of infertility. So it's a must know if you have not checked it out, or if you want to revise or recap pelvic inflammatory disease, please do check out the video in the playlist. Then we have imaging. You can do the transvaginal ultrasound, you can do the saline sonography. This is where they put an ultrasound after infiltrating with saline. Now the saline is going to be dark, and it will act as a contrast, and it will give you the size of the cavity, and it can help you see where there is a distortion by some because of fibroid. Hysteroscopy, where a hysteroscope or an endoscope is used to visualize the fibroids within the uterus, and sometimes they can do a biopsy if required. Then MRI is also the best for mapping, because MRI is very good, has a very good resolution for soft tissue. So when you do an endometrial biopsy, it's going to be recommended, especially if you have anyone with the age greater than 45 with abnormal uterine bleeding, if you have persistence intermenstrual bleeding, if you have obesity or polycystic ovarian syndrome, if you have failed treatment, if you have tamoxifen. Remember, tamoxifen sometimes can be associated with some cancers. Then if you suspect cancer, then you want to do an endometrial biopsy by all means. So the diagnosis is going to be based on the symptoms, the exams, and the ultrasound, and then you want to classify them by the size, the number, the cavity distortion. And it's good to remember that abnormal uterine bleeding due to fibroids is the L in PAM-COEN. So in PAM-COEN, you'll have the L, which is going to be standing for Leiomyoma. The A is for adenomyosis. And remember, we shall do a video about the PAM-COEN where I'll explain the structural and the non-structural or the endocrine causes of abnormal uterine bleeding. So when you look at the management principles, when it comes to fibroids, it's going to depend on the symptoms, the anemia, the size, the number, the location, fertility desire, uterine preservation, and age. And I'm not going to go very deep into the management. I'm going to highlight very fast the different principles that we follow. So you want to, if they're asymptomatic, you want to reassure, you want to give treatment, and you want to review the growth or the symptoms that are associated with these fibroids. Then if of course they're having any symptoms, then you want to go ahead and consider the medical management. It can be supportive, where you replace the iron because of the iron deficiency anemia, and sometimes you may need a transfusion. If there are none, if there is, the other thing that you can consider is the non-hormonal methods of controlling the bleeding. You can give tranexamic acid, which helps sterilize the clots to reduce the heavy menstrual bleeding. It is non-hormonal and is fertility friendly, because think about it, this is a woman who made come, she has fibroids due to infertility, but she also has heavy menstrual bleeding. If you put her on contraceptives, then she's not going to be able to produce, or you are inhibiting her from getting pregnant. So what you do is that you want to use a non-hormonal method that can be tranexamic acid to reduce on the bleeding, and then you give her NSAIDs for the pain, and it may also help with the mild bleeding reduction. Then of course, if there's no fertility desire yet, then you can consider the hormonal, and the levonorgestrel intrauterine system is the one that is highly considered, because you're going to place it once into the uterine cavity, and it will provide those steady levels of progesterone throughout. You can use the combined oral contraceptive pills that is going to control the cycle as well as provide contraception. Progesterone can be oral, can be depot, can be a POP. and it's going to also help in suppressing the bleeding. Then we have the fibroid shrinking drugs, and these ones are not an alternative to surgery, they are an adjunct. So you give a fibroid shrinking drug, it's going to help reduce the size of the fibroid, and then you can go ahead and operate when the fibroid is smaller. So we have the GnRH agonists, and these ones are going to cause what we call a pseudo menopause, and the side effects are going to really look like menopause. They're going to have hot flashes, vaginal dryness, and bone loss. And this is because when you give a GnRH agonist, you kill that pulsatility of GnRH that is actually important for the right hormones to be made. So if it's just GnRH always there, then you are going to not have the different hormones like luteinizing hormone, follicle-stimulating hormone being produced well, and the cascade is going to follow downwards. You won't have estrogen being given off. So you want to do this preoperatively to reduce on anemia. Then again, as a short-term bridge, we have the GnRH antagonists. These also are going to do the same things, and we shall have moderate severe symptoms, and we may cause bleeding reduction as well as shrinkage. Then we have Filipristo. This one is restricted due to its risk of river injury. So we have the procedures, the surgical ones, where we have the hysteroscopic myomectomy. This is the best for people with infertility, where you can go ahead, that's FIGO 0 and 2. When you have a submucosal fibroid, you can go into this hysteroscope within the uterine cavity and then try to remove it. Remember, these fibroids have a good capsule, so it's really not so hard to remove the fibroid intact. Then the myomectomy, this one can be a fastigious-sparing removal, where you go ahead and you can use a hysteroscopic or laparoscopic approach, or you can go open. You do a laparotomy. So the risks of it is that there is bleeding. Remember, a uterus that has a fibroid poorly contracts, and that can lead to a lot of bleeding. Sometimes it causes adhesions because you're opening the personal preparances, and also the risk of future cesarean sections. Remember, whenever you put a scar on the uterus, the chances of this mother pushing again diminish because of the high risk of rupture. So once you operate with a myomectomy, then you're most likely going to go again with cesarean section. Uterine artery embolization. This one is where you embolize the uterine arteries. Of course, when something doesn't have a blood supply, it's going to undergo shrinkage. There is fibroid shrinkage, and it's good for heavy menstrual bleeding, or where we have bulk fibroids, and you feel like if you start picking them apart, you may have nothing left of the uterus or things like that. So you want to do the uterine artery embolization. And the problem with this is that sometimes it causes a decreased ovarian reserve, and once you have enough decreased ovarian reserve, then your years of reproduction are going to be heavily reduced, and that would cause a fertility concern. So endometrial ablation, this is where you have the bleeding of the endometrium that is very much, so you go ahead and ablate the endometrium, burn it away, and this is going to control the bleeding. But the problem with that is that there will not be pregnancy, because the endometrium is important in creating that interface between the child and the placenta, and once you remove it, then you're going to have issues with that. Hysterectomy is the definitive choice whether you remove the uterus, because without the uterus, then there is nowhere for the fibroid to be formed. And there are other methods or modalities of management, but those are very niche, and we're not going to cover them here. So we have come to the end of this video. My name is Benjamin, and this was fibroids. If you really did enjoy the discussion, go ahead and subscribe to the channel, leave a comment, leave a like. We shall meet in the next video. Hope you have a nice time.